Well, thank you very much. I was asked to speak about stigma from the perspective of health providers, but I decided I'd make an executive decision and talk about stigma in healthcare because I think it's a much bigger issue than just healthcare providers. And as Pat has just mentioned, there are a lot of structural issues that get waylaid if you don't think about it in broader terms. So that's what I'm going to try to do in my time. Well, there's no doubt that stigma is a healthcare issue. We've heard it over and over again today. It's experienced by many people as worse than the illness itself. It's more long-lasting, life-limiting, and disabling than the mental illness. So this makes it an important therapeutic issue, I think, and something that every healthcare provider in Canada and elsewhere ought to be concerned about. It interferes with the receipt of appropriate care. We've already heard that. And that means either care for a medical or a mental condition. It impedes recovery, it entrenches disability, and it contributes to lower than average life expectancies for people who have a mental illness. This is something that makes it all of our responsibility as healthcare providers to think about and to address. Internationally, there's increasing recognition that stigma is a key barrier to mental health reform and actually social justice. The fight against stigma and its consequences has been considered by a number of international organizations now to be the most important challenge of our time. Here you see a couple of them listed: the World Health Organization, the World Psychiatric Association, World Association of Social Psychiatry, and of course our beloved Kirby Commission in Canada. All of these and many more have made proclamations about the importance of fighting stigma and discrimination. And some have also pointed to the responsibility of healthcare and healthcare providers for taking a lead in this in respect to fighting stigma and discrimination in the context of the health encounter. So we've heard a number of things already today, and this may be a bit of a summary of what we've heard, perhaps a synopsis. The implications are dramatic for quality of care for people who have a mental illness. There are entrenched inequalities in the system, a policy vacuum related to mental health initiatives. We see that in many places in Canada and elsewhere. A lack of funding for programs, we've heard that in various ways already. A suspiciousness about the efficacy of psychiatric treatments. We know that mental health professionals are held in low esteem by our medical colleagues. In fact, anybody who has anything to do with mental illness or mental health is held in low esteem by our social group. And all of this results in highly inadequate care for people with a mental illness. And this is not only because mental health services are underfunded or difficult to access, or in some parts of Canada completely non-existent, but it's also to do with the medical care that people with a mental illness do not receive. We have tremendously poor system outcomes in these situations. There are human rights abuses, still in Canada today, human rights abuses, although more flagrant abuses, I think, in many developing countries. Generally poor quality of services, inequitable access to care for people with mental health problems. When you're running services that you can see have poor quality of care, have poor facilities, are underfunded, poor remuneration for the employees, it makes it very difficult to attract high-quality professionals. So oftentimes it's difficult in mental health circles to attract the best and the brightest. They come because they do it for love, not for money, but many times our colleagues try to dissuade people from making a career out of mental health practitionering or research. We've talked already in the audience about the lack of funding for mental health research. This is evidence of yet another inequality or inequity. And so what that means is the production of new knowledge about mental health services, interventions has slowed relative to other equally disabling conditions. And we live today in an evidence-based world. Evidence drives everything from what kind of pill you're allowed to take to what kind of policy should be implemented. If our funding for this kind of evidence is restricted, we have lost a very important advocacy tool, I think, as a community. And so we find ourselves in a catch-22. We can't argue for better services because we don't have the evidence to show that they work. And until we get more evidence, we're not going to get any farther, but we don't have people to collect the evidence because it's not a very nice place to be, because psychiatry isn't seen as interesting. So we're entrenching these inequalities in the way the system has been set up. So this is building on what Pat has said. So let's look a little bit at the treatment disparity research, and this is some of the work that I did with Maura Ricketts, the Canadian Medical Association. First, I'd just like to tell you what a treatment disparity is considered to mean. It means that your membership in a group is associated with healthcare treatment or outcomes that are unjustified by your underlying clinical need. So it's not necessarily a difference or an inequality. It means that you needed something and you didn't get it because you were a member of a particular group. So somehow you were significantly disadvantaged. And so the issues for us then, in terms of treatment disparities, are whether people with a mental illness receive appropriate care, first and foremost for their mental illness. Do they get what they needed? And second of all, for any comorbid physical illness that they might have. And we can document a number of horror stories in this area when we start to think about the high prevalence of comorbid physical illnesses among people who have significant mental illnesses and the lack of access to physical health care. We did, with the Canadian Medical Association, a systematic review. We were looking for studies that documented treatment disparities. We weren't too concerned about the outcomes, whether we were talking about cancer, cardiovascular disease, health promotion, prevention. But we reasoned that if discrimination was significantly entrenched in the way in which practitioners behave, the way in which physicians behave in confronting the patients in their offices, we should see some pretty systematic results in the studies. We should see that most of the studies show that there are significant disparities in the way that practitioners deal with their patients. And you can always find people to cite the negative, the bad results. What we found was kind of interesting. Of the 29 studies that we were able to identify at the time, 5 showed that people who have a mental illness got comparable or better care. These are all very large, well-done studies. Unfortunately, most of them in the United States. At this time, only 1 was done in Canada. 8 showed evidence of a significant disparity. In other words, people who had a mental illness did not receive guideline care for whatever outcome the paper was looking at. And of the remaining 16, the bulk of the study showed mixed results. And what that meant is it depended on where you were in the country. It depended on what the outcome was that they were looking at. Many studies looked at mixed outcomes, so preventive care might have been good, but some other type of care might not have been so good. It depended a little bit on your diagnosis, so sometimes people with depression would get okay care or better care, but people with schizophrenia wouldn't. And in some other places it was the reverse. People with schizophrenia got better care, people with depression didn't. What these kinds of results tell me is that, again, it's pointing more to system and structural issues, that people who have prejudices may keep their attitudes to themselves, that may actually not always express itself in behaviors. There doesn't seem to be entrenched discriminatory behavior here to me on the part of physicians. But I think what happens is we get involved in organizations where there are entrenched biases to the way that we provide care. But having said that, we do know that psychiatric treatments are viewed with tremendous suspicion, and this may be something that lends itself to inequities, vilified in some cases, sensationalized, portrayed as helpful or mind-altering. I've had conversations with colleagues in my own department who say to me with a straight face that if they ever got a mental illness, there's no way they would take mind-altering drugs. There's no way they would. And it just shows me that there's such a naivete on the part of the public and such a suspicion about the treatments. I don't think anyone would ever say that about diabetic medication, insulin, or maybe cancer drugs. More often than not, psychiatric medications are presented as having unacceptable side effects. Now, many of them do have side effects which are quite horrendous, but some don't. And so it's a stereotyping of the medications and the interventions that we have. And oftentimes they're considered to be just too costly. So I've worked in hospitals where we've had to gather evidence to argue for new drugs to be included in the formularies. And it's a really tough sell to get a new psychiatric medication into a hospital formulary. They would rather have other kinds of drugs, obesity drugs, cancer drugs. And by saying that the drugs are just too costly, it's just another way of saying that the people who need these drugs are not worth the cost. What you see here is an article that was presented in last month's Canadian Medical Association journal to show that we, in our own professional groups, also vilify psychiatric treatments and sensationalize them and make them into really scary things. This was a review about the United States reviewing the safety of electroconvulsive therapy. And the picture here is reminiscent of some of the early One Flew Over the Cuckoo's Nest type pictures. And actually, I have an old picture that I'm going to show you just to show you how similar they really are. I don't know if any of you have ever gone to some of the international congresses, the World Psychiatric Association being one of them, and you have to walk the gauntlet. And what I mean by the gauntlet is there's a lineup of people on either side of the walkway getting into the Congress facility with placards and megaphones screaming in your face and sometimes spitting on you about how you kill people, how you destroy their brains. In some countries, they will let them come very close to you and almost push you and jostle you. In Canada, that's not the case. Well, the last time that this happened to me was in Greece, and this is where I got this blue picture, but I've seen it so many times before. It's one of the Scientology pictures. And I decided that this time I would walk the gauntlet by stopping and talking to everybody who wanted to give me a leaflet and take their leaflets and take them home and see what was in them. Usually I just kind of bulldoze my way through. So I couldn't read any of the leaflets, but I could look at the pictures. So this picture is one of the pictures that they are using to argue that psychiatry is basically killing people and destroying their brains. And if you compare that to the more updated version that we saw last month in the Canadian Medical Association journal, it's not too far different. I mean, it's a little bit more modernized, but I think the intent was still the same, frankly. So, we have to really do some process checks on our own behaviors at times. So there's no shortage of atrocity tales. Even though we can't find necessarily systematic evidence in the disparity research, we can certainly find atrocity tales in abundance. And here are some that we took out of the Shadows report. Remember that this was the report that the Mental Health Commission used to build the commission, and they collected information from some 2,000 Canadians. What you can see here is that people are resenting the fact that their illnesses are not as important as other medical conditions. They're made to wait inordinate amount of times. I spoke to a woman the other day whose daughter is quite ill here in Ottawa, and the first time she can get an appointment with a psychiatrist is in 8 months. I think by 8 months this lady may not still be alive, but there's just no way to get her in any faster. People who feel condescended to and belittled by many of the doctors they come across. And here's the last comment: I don't tell people I'm depressed. For example, I don't tell a medical doctor because it changes their attitude right away. The thing that we don't know is how often these kinds of things occur. We don't have systematically collected information that would help us quantify the scope and the magnitude and the location of these kinds of problems, but we certainly hear about them. What we're working at the Commission in the Opening Minds program is to try to get some information that portrays the experiences of people who have experience with mental health problems, because we think that it's important for us to be able to say that this is where the problems lie, these are where the programs need to be targeted, and here's whether or not we're making progress by changing stigma and discrimination. So over the last couple of years, one of our resounding successes, I think, and there are people in this room, including Phil and Mike Petrus, who helped us along this way, work with Statistics Canada, which is our national reporting organization, to develop a very small stigma module to assess two things. We wanted to know about how Canadians devalue people with a mental illness. And because people think about different mental illnesses in different ways, we wanted to focus. We chose this time to focus on depression, but we could focus on another category or label at any other time. But more importantly, what we wanted to know was what the personal impact of stigma was among people who had reported some treatment for a mental illness in the year prior to the survey. This is, to our knowledge, the first time that anybody has bothered to ask people who have been treated with a mental illness what the impact is in any kind of systematic way. So we don't know of any other population data on this. We have funded through the Opening Mind programs a rapid response module, and we actually have data now in our possession on 10,000 Canadians for analysis. I think we actually may have some Aboriginal codes in that data, so if you're interested, come and talk to me at the end. But more importantly, this module is going to be included in the 2012 Community Health Survey that will be collected on some 30,000 Canadians, and it will give us a full range of information from the CCHS modules. Not only will this support research and build capacity in our field, but it's going to help us for the first time understand what are some of the determinants of stigma, and more importantly, I think, what are some of the determinants of resilience, because as it turns out, not everybody reports a stigma experience. So, I guess to kind of maybe pick up on Maura's comments, what can we do? I need a plan. What can we do against such monstrous giants as the ones that we've been talking about all day? Well, I think we have to engage them in fierce and unequal combat. And the way in which we can do that is by using some common sense, some evidence, and some partnerships. We all know that anti-stigma programs are proliferating around the world. Everybody seems to respond now that this is a target worthy of fighting. And growing numbers of organizations, including all of us in this room, are interested in reducing stigma and discrimination. Many groups across the country and across the world have launched multi-year anti-stigma initiatives. But the majority of these are not evidence-based. They're not even evidence-informed. Usually they're based on strongly held beliefs about what will and will not work. And that would be okay, other than the fact that resources may be wasted. But as Pat previously pointed out, depending on what we do, we actually can cause a lot of harm. So if we provide the wrong messages or take the wrong approaches, we're actually going backwards. And so what we want to do is tread very carefully and make sure that what we're doing is our best evidence of the day and that we're carefully monitoring to make sure that we're not going in the wrong direction. And what makes this really challenging for us is there's hardly any evidence out there to support what we're doing. Again, it puts us behind the 8 ball as a group of people wanting to diminish stigma and discrimination. Here are the number of articles, just to give you an example, in Medline and PsycInfo. These are two of our main academic databases, but also the two databases that tend to focus on applied research as opposed to the theoretical research we'd see in sociology or psychology. Starting in about 1995, there was like 2 articles that were published with stigma in the title or the abstract. And that's increased quite dramatically over time. But all we're seeing right now is only about 300 articles a year right across the whole spectrum of academia. And that's less than 1%, perhaps, of all articles that are published in the area of mental health. So when it comes to an applied database that can help us argue for what's right or wrong in this area, what is or is not a best practice, we really don't have enough evidence. So one of our concerns needs to be is as we move forward, we need to be building an evidence base as we go. In the spheres of health, there are 3 levels which we've seen already, 3 spheres of action, and these are interconnected, I think, and multiple reinforcers. But at the structural level, we've talked about health systems and health organizations. Maybe we need to start looking at inequitable or unfair policies and practices and documenting them in the same way that maybe Pat has documented his legislation in the United States. We have inadequate and outdated facilities, and there's no reason why we can't start systematizing a description of these using some sort of a standard that we apply. Dirty carpets and broken chairs in the lobby would be 2 examples of things that we could put on the list. As we don't want plexiglass as you walk into an outpatient facility might be a 3rd that we would identify as something we don't want to have. At the group level of clinical practice, we need to think very carefully about clinical stereotypes and inaccurate assessments of disease risks. So many times we think that physicians may not offer treatments to people with serious and persistent mental illnesses because they misunderstand the risk associated with those treatments. And that might be a simple educational intervention. But diagnostic overshadowing is more serious. I think it's based more in a prejudicial view where everything becomes explained in the context of the mental illness. So people, we've heard stories already today, people go in for a medical encounter and end up receiving a psychiatric encounter instead. Pejorative interactions with patients and families, we have to check ourselves. We have to be honest enough to recognize that these are happening, and to start to think about how often they're happening and what can we do differently about them. And at the patient level, we need to provide avenues for redress, and we need to encourage patients and families to take those avenues. If you don't feel that you're getting appropriate care, what do you do? Where do you go? Who's there in your side in your court to help you? There's something to be said for stigma management. I think that some people are resilient and have learned over many years perhaps how to get along and how to manage stigma and how to rise above it. That's the essence of recovery, isn't it? Rising above the stigma. And what can they tell us about how to do this? And is there a way that we can learn from these experiences and help others? We also, as I said, need to measure personal impact. So we're trying to do that through our rapid response survey and through the stigma module. But unless we start to really pay attention in a systematic way to how stigma is affecting people on the ground in their day-to-day lives, we are not going to be able to demonstrate change, and we're not going to be able to evaluate our programs, and we're not going to be able to advocate. We need coordinated and long-term programming that is sustainable, and we need to think very carefully about how we're all going to work together to make that happen. We need to address the structural inadequacies because I think that they can govern people's behaviors in ways that we want to fix. Even people who are very open and liberal and non-prejudiced will act in discriminatory ways if they are in organizations that require them to do that. We want to focus on behaviors. Both in the World Psychiatric Association and in the Opening Mind program, we recognize that people may have stereotypes and may be prejudicial. But, you can keep that to yourself. What we really want to change are the ways in which you behave. And maybe what will happen over the long run is if we change your behaviors, attitude change may ultimately follow. But if it doesn't, it doesn't. What we want you to do is be better in the way that you behave. So we want to focus on behavioral outcomes. And we want to increase best practice knowledge through research and evaluation. So there's lots of room here in this kind of a framework for multiple partnerships. Everybody has a role to play and everybody can contribute something. Just to give you some ideas, the Opening Minds program is targeting at least 2 groups, a third now, workplaces, but at this time we were targeting 2 groups. And we issued a request for information. We decided that it was more important to build grassroots sustainability than to make proclamations from the top down about how to fix stigma and discrimination. We wanted to recognize that groups are already out there working and to build on their work. And we had 103 programs request partnership arrangements with the program who targeted youth. These were often the school-based programs we heard about this morning. And we had 130 healthcare providers who felt that they were running anti-stigma programs who wanted to have a partnership with the Opening Minds program in order to conduct evaluation and develop best practices. And what you see down the characteristic column of the chart are some of the characteristics of the programs that were responded. So level of consumer involvement. I think consumer was an okay word then, but it's not so much an okay word now, so please bear with me. This is a little bit of an outdated slide. But the direct contact is what we've been hearing about all today, based on the contact theory that puts people who have a mental illness with lived experience in contact with people who don't in a very positive and partnering environment. And what you can see here is of the youth programs, most of these programs are run by people who have a mental illness. 29% had direct contact, and unfortunately only 20% of the healthcare provider programs had direct contact, and this is what we thought of and still do think of as the best practice in the field. So what this tells us is the bulk of anti-stigma work that we could discern through this process is not based in what we understand as the best or most promising practice. So there's a lot of room there for seeding and educating the programs that are working and bringing better evidence out to the field. What you should notice is 69% of the healthcare provider programs had no consumer involvement whatsoever. And I think that that is something that absolutely has to change. A heavy reliance on education. Healthcare providers are very much treatment-oriented. I suppose we can forgive the healthcare system for that. It's what we're all taught to do. The other thing I want you to pay attention to is that many of the programs, even those in the health system organized by health providers, did not have stable funding. 57% said they had stable funding, and the rest weren't sure. It's very difficult to develop a best practice using evaluation models if you don't know if a program's going to exist a month from now. It's really not worth the effort. The other thing that this tells me is organizations who have agreed that stigma and discrimination is fundamental to the recovery process, to the treatment encounter, to everything that we want to accomplish, and they cannot muster stable funding for anti-stigma initiatives. So I feel that this suggests a lack of responsibility on the part of the health system to really embrace this issue and feel that it's something that they should be doing, incorporating into their day-to-day activities and making sure that there are appropriate systems and funding in place to do this. So actually we invited a number of programs to work with us, all the best practice models, and we do have quite an extended network now of healthcare provider programs and youth programs and now workplace programs that are working with the Commission, developing new methods, evaluating, refining, and then creating toolkits for people to use. Along the way, things that I think that are getting in our way and that we have to also give some consideration to is our failure to recognize that stigma is primarily a problem of behaviors. It has nothing to do with literacy. It has nothing to do with attitudes. In fact, sometimes the behaviors drive both what information you'll attend to and pay attention to, and also the structures that we work in will govern our behaviors. It may have nothing to do with our attitudes. We have a failure to recognize that the fundamental goal of what we're doing is to bring about meaningful changes in the lives of people with mental health problems, their family members, and the policies and programs that are intended to support them. So it's not just as simple as increasing awareness. It's not just as simple as changing an attitude or providing facts to people. We want to see real on-the-ground change, and this is a very high standard to set. But if we don't set the standard high, I don't think we're ever going to accomplish this. Things that get in the way, fear and denial in the healthcare system. Increasingly what we've noticed as we've worked with different professional groups, comments like, well, we know that stigma exists and it's a problem, but we in our group don't stigmatize. Like, our professional group is okay. A failure to realize that we all stigmatize. We've been taught to. We've grown up in the same culture. We do it, even unconsciously. So this is something that's really going to get in the way of the health system doing things in a very positive and proactive way. And the other fear is, well, we know it exists, but we really don't want to point fingers at anyone. So we can't collect data to show, people are very afraid if we collect data about patients and what their experiences are that we're pointing fingers. I think we have to buckle down at some point and just say, look, we need this information to help us. And yes, we're stigmatizing. We may be, but we need to know where, and we need to know how, and we need to figure out how to do this differently. There's been a tendency to politicize anti-stigma activities. going for the big bang, the visibility versus the meaning. So, the large, glitzy campaigns as opposed to the grassroots development and the community-based development. Grand gestures, in many parts of the world, big, expensive 5-year campaigns without any thought to how they're going to be sustained after that. And we know they have to be, because in order to make this work, we need to have transgenerational programs that go on long beyond us. The Big Bang theory of social change is what I call the idea that one sort of quasi-potent intervention can change the way people think and behave and act for the rest of their lives. It's not going to happen. We have to get into schools, we have to get into workplaces, we have to get into healthcare systems, and we have to stay there. And the misplaced faith in conventional education and social marketing approaches, I think these are approaches that are just not potent enough for the kind of prejudices and behavioral outcomes that we need to change. And they're usually expensive. They take a lot of our meager budgets. When we evaluate them, we tend to find that they don't produce any results. And the worst outcome of all is that we give funders and policymakers and everyone out there the impression that stigma can't be beaten when we take these impotent approaches and apply them in inappropriate ways. And that's the last impression that we want to convey, because stigma can be beaten. I've seen it. So to summarize, we know from our conversations today and from the literature that stigma is complex, it's pervasive, it exists on multiple reinforcing levels, personal level, interpersonal, social, cultural. In healthcare, it undermines every single thing that we do: the therapeutic encounter, the quality of care that's provided, the delivery of services and access to care, the production of new knowledge, and patient recovery. It's rooted in deep-seated fears that are not amenable to change, and we're going to need long-term, multi-pronged programs aimed at changing our own behaviors. We must start inside, I think, first, and then think about everyone else. And we're going to need to develop best practice knowledge as we go. I have one last slide, but this is a plug. This is a new journal that we have started. Some of us in this room, Pat is on the editorial board, myself, and some of our other colleagues internationally. We call it Stigma Research in Action. We've just produced our first volume. It's online. If you search for Stigma Research in Action, you'll find it. It's a stigma research in action against any stigmatized group, not necessarily mental health. We believe that we can learn from each other, that what has happened in the AIDS community or minority group, that some of the same processes might apply to us. We take anything, from academic reports to personal accounts to opinion pieces. We're gearing up to have a debate on the use of the term stigma, or should we retire this word entirely. So I think our next issue or the one after that will contain information on that debate. I would encourage you to consider this journal, this new journal, as an avenue for some of your own work, and we would be happy to receive submissions.